millions of people worldwide. Now, according to the CDC, 1 out of every 500 Black and African American is affected by 1 out of every 500 births of African Black Americans have sickle cell disease, and out of every 36,000 Hispanic American is affected by sickle cell disease. Hi, my name is Francisca Osage. Welcome you to another webinar series on the complete wellness. And yes, today we're going to be discussing on sickle cell disease. Now, according to the CDC, I go back to my stats. We have millions of people affected worldwide throughout the world. However, people that hail from areas of various common ancestry from areas of sub-Saharan Africa, Central and South America, the Caribbean, Saudi Arabia, India, Mediterranean countries such as Turkey, Greece, and Italy are affected by sickle cell. And for my audience in Nigeria, do you know that Nigeria is the sickle cell capital of the world? You have 2% of births annually affected by sickle cell, and that comes out to 150,000 of births affected by sickle cell. And that 150,000 is actually half the number of births worldwide that are affected by sickle cell. So that's quite a high number. Now, for those living in prevalent areas, areas prevalent with sickle cell, you can never overstate the impact, the toll on the quality of life it has. Talk about the health impacts, the physical and mental health, the social and economic implications, talking about finances and the time, resources, and all. Most especially the pain crisis, the recurring pain crisis. It is hard. Anyhow, welcome back. And as always, it is a delightful pleasure to have you all today. Today, we're going to be having a panel of guest speakers who are expertise and authorities in the areas of the management of sickle cell anemia. Now, sickle cell anemia is a category of sickle cell disease. We're going to be emphasizing on the management of sickle cell anemia. And in introducing this guest, if I were to actually talk about their professional and academic achievements, trust me, the time allotted to this webinar is not going to be enough. So permit me to really highlight the academic milestones, the professional milestones of achievements our speakers have. So I'm going to introduce, start on with Dr. Zainal Abidin. I believe we have, you see, Dr. Zainal Abidin is a pediatric hematologist and oncologist. He received his medical degree from the Calicut University in Kerala in India. Then on went to achieve a postgraduate in pediatrics at the University of Mumbai. He then went on to the UK, where he achieved a master's in pediatric oncology at the Birmingham University, and also an international fellowship in pediatric bone marrow transplant from the Great North Children's Hospital in Newcastle. So currently, Dr. Abidin is affiliated with the Burjeel Medical City in the UAE. He's recognized for several publications and achievements and awards, including the International Fellowship in Bone Marrow Transplantation at the Great North Hospital in UK, as well as pediatric fellow of pediatric oncology from the Royal Marsden Hospital, Imperial College, and the University of Hospitals in London. So Dr. Abidin, thank you so much for honoring an invite. It is an honor to have you.
Thank you. Thank you very much for your nice introduction. I'm also very pleased that I'm here with you.
Thank you. It is an honor to have you. And unfortunately, I couldn't meet you before now at the breakout room, but nice meeting you. Our next speaker, another innovator in the field of stem cell transplants, and she's a very recognized achiever. I'm talking about Dr. Mansi Sachdev. Dr. Mansi Sachdev is another pediatric oncologist and hematologist. She also obtained her medical degree from the Sri Devaraj Oz Medical College in Karnataka in India. She then went to the USA, where she did a residency in pediatrics and also a fellowship in pediatric oncology and stem cell transplant from the Penn State Hershey Children's Hospital in Pennsylvania, USA. She then obtained also a fellowship in pediatric stem cell transplant and cellular therapy from the St. Jude's Children's Hospital in Memphis, Tennessee. Currently, she's affiliated with the Virgin Medical City. Now, like I said, she's an innovator. She is highly recognized for several transplant procedures, over 400 transplants. And there's some exceedingly rare conditions like haploidentical transplants. And she's an innovator in hematopoietic stem cell transplant. So thank you so much, Dr. Mansi, for honoring this invite. It's an honor to have you here.
Dr. Sajid, thank you. Thank you very much for inviting us here. And, we are pleased that we'll be talking about sickle cell disease with all of you.
Thank you. And finally, our guest, not necessarily our last guest, but the third person I'm going to be introducing is someone you all well know because he's previously graced this webinar talking about symptoms of eye flashes and floaters. And he's here to talk about one of the complications of sickle cell, that is sickle cell retinopathy. I'm talking about Dr. Farhad Kahil. For those of you who don't know, Dr. Farhad Kahil is a consultant ophthalmologist affiliated with the Moorfields Eye Hospital in Dubai Healthcare City. And yes, he's a specialist. His specialty include medical retina and ocular inflammatory diseases. And he obtained ophthalmology training from UK as well, from Birmingham, London, and Oxford, and also a fellowship he got from Wolverhampton, Birmingham, and Moorfields Eye Hospital. He's known for his publications in several literatures involving retinal diseases and ocular inflammatory disease. So once again, Dr. Farhad, it is an honor to have you. Thank you for honoring this invite. Welcome.
Oh, no, honestly, it's a real pleasure. And thank you for the kind invitation. I really appreciate it.
Thank you so much. So to our viewers again, it is also an honor to have you all taking out your time to participate in our webinar. And it is the main thing, the main reason we have these sessions is you have that time to interact with people that are experts. The best of the best is who we actually try to get. And we're so lucky when they actually come and speak to us, educate us on these areas. So we would also like you to participate by asking questions, putting up in the chat so we can ask experts these questions and have you all informed. So today we're going to be talking on sickle cell anemia, the management of sickle cell anemia. There's so much to talk about. So let's start with unloading, cut straight to the chase. And I'm going to start with you, Dr. Zeno. So the concept of sickle cell anemia, can you give us a basic insight to that concept, and also how does it how is it inherited? Dr. Ibidin?
Yes, thank you. So I think it is very important basic question we all need to understand about sickle cell disease. So basically, sickle cell disease is an autosomal recessive disease. It is a kind of genetic disease. So what is autosomal recessive disease means? It is inherited from parents. For a disease to happen, there are two mutations. You need a baby born with a sickle cell disease means this baby should have got two mutations, one from father, one from mother. That is how the autosomal recessive disease manifest. So basically it is a genetic disease and autosomal recessive. If both parents are carrier, there is a 25% chance that the children can get sickle cell disease. There is a 50% chance that their children can be carrier and 25% chance that they can have completely normal child. So this is how it inherit. Apart from this, you can also get sickle cell disease manifestation if a carrier with the sickle cell disease and a thalassemia carrier having baby. It's called sickle cell beta thalassemia. They can also present as sickle cell disease. This is all about transmission as well as the genetic aspect of sickle cell disease.
Thank you so much. Thank you so much, Dr. Zeno. And a little bit of a follow-up on that question. You know, you didn't talk about it being an inherited disease of the red blood cells. And in talking about the transmission, I remember learning, and I'm sure some of our viewers will have sort of been exposed to this pedigree diagram where you have carriers, the AS, you know, their progeny. You have four outcomes, you know, in the first degree progeny. You have the AA. So the AA has no traits or gene for the sickle cell. However, you have the other three, two of which are AS, and the last is the SS. Now, can you sort of address that conception? Because you said the 20% chance, but some people have literally interpreted it as, okay, if I'm a carrier of AS traits and my spouse is, and we both have children, that means 1 out of every 4 will be. So if the first one is sickle cell, oh, the rest will not be sickle cell. So there's a difference between the likelihood of that happening, which is what you have described, the chance, 25% chance. But that does not equate to, oh, this is, you know, you will have 1 of 4 children will have sickle cell anemia. Can you just address that misconception quick, please?
Yes, I think, you know, as you explained, there are 2 factors. For example, for normal hemoglobin, we need to have a 2A, one from parents, one parent, father, and one from mother. So that means if 1A from father, 1A from mother transmitted to child, that means they will get hemoglobin AA. That means it is completely normal. If 1A from father, yes from mother, then it will be AS, that is a carrier. But if both of them are carrier, that means they will have 1A, 1S. They will, father and mother will have 1A, 1S. So by chance, if both S from both father and mother transmitted to child, then it becomes SS, that is the sickle cell disease. So that doesn't mean that for each child, the chance will happen. For example, you can have a family with 4 children and all of them can have sickle cell disease. And you can have a situation where 4 children, they don't have any sickle cell disease. So for each baby is 25% chance. It is not a whole family package.
Okay. Yes, thank you so much. So that it's because like I said, I've heard of cases when someone is counseling maybe a couple and they actually tell them, or the couple receive it as this will be, but it's a case of probability. Okay, so our next question, Dr. Sachdev, you actually, you have that international experience, both in the UAE, in India, in USA, and many other places. Can you tell us about your experiences when it comes to the management of sickle cell? What do you perceive, you know, regarding the management of sickle cell in these various places? Can you address that?
Yeah, sure. And thanks for the question. I mean, it's a complicated question to answer, but I will try my best to kind of answer in the way that I have been through my journey so far. So I'll start with when I started my residency and fellowship in the US. You know, this was back in 2008 is when I started. And for 6 years, I was in Hershey. And as you know, sickle cell disease, you know, it's not prevalent everywhere. It's not equally divided in the world, as you rightly said, that, you know, it's a sub-Saharan Africa, parts of India, Turkey, Greece, Mediterranean, Southeast Asia, and places like that. But even in the US, there are actually regions or belts where, you know, sickle cell disease is very prevalent. And I was in Pennsylvania, and we had a good share of these sickle cell patients, basically because of these patients who were from African descent. So they are the ones who've been suffering from sickle cell disease. And, you know, we didn't have a lot of patients at that time in Hershey, Pennsylvania, but we had quite a share of these patients. And I was fortunate enough, one of my mentors was actually very interested and was the core person who was doing sickle cell anemia clinic in our hospital itself. And we were doing more so of the, you know, the prevention and the supportive care for these patients, meaning, you know, the neonatal screen was there. We were doing a lot of hydroxyurea. We were doing a lot of penicillin prophylaxis, immunizations, and things like that. But we were not hardcore on transplant. We were not hardcore on stem cell transplant at the time, which kind of doesn't hold good true today. But in a part it does, and really also in part is dependent on, you know, what you believe is the best for that child at that moment in time. And at that time, really stem cell transplant was evolving. It was not where we are today. We were still evolving as a transplant community. So we were mainly managing these sickle cell patients with supportive care. Having said that, after 6 years of my residency and fellowship, when I moved back to India, now again, in India, sickle cell disease is not prevalent everywhere. It's only in a belt, mainly in parts of, you know, Gujarat, Maharashtra, Chhattisgarh. Those are the places, and tribal. And it's usually tribal population in India who's been really affected by sickle cell disease. So I was in a metropolitan city. And again, so we were not seeing a lot of sickle cell disease patients. And the majority chunk of the patients that we were seeing were for bone marrow transplant. And I'm talking about like 2018, 2017. So there has been really I wouldn't say a paradigm shift, but really a shift in how we were managing sickle cell at that time and how we are managing sickle cell today. Not saying that we are not doing hydroxyurea, penicillin prophylaxis, immunizations. Those again would count for majority of the patients even now, but that's more supportive care. But now more we are looking for is cure for these patients who have sickle cell disease. Fast forward to now, which is 2023, and we are hardcore doing stem cell transplant for these patients, and there's so much going on in the transplant world as well. Especially, you know, the half match transplant, the gene therapy and things like that, that we are moving really, really fast. So that's my journey from, you know, where we started caring for these children. We were, no, I wouldn't say we were struggling, but we were really seeing and doing supportive care. Now we are doing more curative treatments for these patients.
Yeah. So what I'm hearing now, really, when you started off as a pediatric oncologist during that early time, and this was mostly in the US, there was really that, we talked about the use of medications like hydroxyurea, penicillin prophylaxis and all. But in the recent times, and this is time now you're in UAE, because of the advances, we actually talk about transplant now, bone marrow transplant. So this is like an innovation, a recent one in the
No, I wouldn't say it's an innovation. It has been there for quite a long time. Just that the way things are that we're doing now are much more in a sophisticated manner. The rate of infections are less because we are managing these infections in a better way. We know how to manage the complications. We know how to prevent these complications from happening. You know, transplants were even happening in 2008, don't get me wrong, but the successful transplants that are happening now, you know, we are there because of a lot of things that have changed in the recent past. That's where we are here today. Same things were available, except for gene therapy. You know, transplant was available even like 15, 20 years down the line. But, you know, the way we manage things have changed. We have a better handle of things now.
Yeah. Well, thank you so much for that. Okay, now talking about sickle cell, many affected by sickle cell, like I said, they know just, and you as a medical professional in that area know too well, there is the complications, both acute and chronic, that come along with these diseases. So Dr. Fahad, this is going to go to you now because yes, you're in the field of ophthalmology, but really one of those chronic long-term complications of sickle cell is sickle cell retinopathy. And being an expert in this field, several complications obviously, but we're going to emphasize on just one of those complications, which is sickle cell retinopathy. Dr. Fahad, can you tell us what is sickle cell retinopathy and how does it manifest?
So basically, sickle cell retinopathy is an ischemic retinal vascular complication because you obviously get the sickling of these aberrant RBCs, and it gives you a kind of a chronic vaso-occlusive non-perfusion within the retina. And it kind of ranges from very mild changes where you get the odd microaneurysm, the odd loop or arteriovenous communication in your non-proliferative disease. If you did wide field fluorescein angiography in these patients, however, you would see that there is areas of shutdown within the peripheral retina, manifesting to more serious proliferative disease where the patients now, because of these chronic ischemic changes, has now developed areas of retinal neovascularization, which in about 30% can autoinfarct. So they don't necessarily progress and you can observe them and they get better, but there's the odd patient where actually it will progress, leading to vitreous hemorrhage, or worse still, tractional retinal detachment.
Sorry, I'm going to have to interrupt you there because I'm going to remind you, something I said initially, most of our audiences are in the non-medical field. So
Understood.
try to break it down a little bit. Like you've mentioned, it's ischemic, it's an ischemic condition of the retina.
Yeah, so the blood supply basically is damaged and it's affected. And so you're getting a lack of blood supply in areas of the retina. And in the beginning, it's what we call non-proliferative. So basically, you can see the changes as an eye doctor, because when you examine the fundus, you're able to tell that actually there are changes within that retinovascular appearance, but it doesn't actually necessarily impact on vision.
Okay.
But over time, it can be severe enough that it then progresses to develop abnormal blood vessels. So blood vessels that shouldn't be there, that are weak, that are fragile, that can bleed, leading to bleeding within the vitreous humor, which is a cavity behind the lens and in front of the retina, leading to severe loss of vision. Or worse still that those abnormal blood vessels scar and then lift the retina off, causing a retinal detachment, and you need an operation. Now, that doesn't happen in all of them, because in some patients, a third, those abnormal blood vessels will shut themselves down and will what we call autoinfarct. So they will regress spontaneously without you doing anything. But often you'd have to monitor them carefully, because if they do develop either evidence of bleeding, you want to then consider treatments, which we'll discuss at a later point. But it was something that we were very worried about in the UK. So when I was in the United Kingdom, you know, I had a large contingent, or a lot of my patients were from the Afro-Caribbean community who were afflicted with sickle cell retinopathy. And unlike diabetes, where a huge amount of investment is made by the UK government to screen every diabetic patient, unfortunately, it's not the same cannot be said for sickle cell. So as doctors, we just did it without necessarily involving any government. And we just said to our patients, look, it is a hassle. You're going to have to see me every year, or whatever I dictate will be the review. But if you go to your optician, they're not going to be able to identify the changes. And there isn't any national screening network. So I will just see you on a regular basis to try and identify these signs. But particularly, I was trying to pick up those patients with asymptomatic changes, but have proliferative disease, and consider the intervention potentially to keep them from harm's way.
Thank you so much. So basically, I think the summary of this is in terms of the manifestation now, when you, as an ophthalmologist, you're doing a retinal eye exam, you're seeing a lot of blood vessels, much more blood vessels in the mucosal of the retina, right?
Yes, yes. So in the beginning, you may just see bleeding spots or these kind of irregular blood vessels within the retina, but they don't actually pose any harm or any risk to vision. But it can then gradually progress over time to develop abnormal blood vessels, and those are the ones we worry about because only in a third will they spontaneously regress. The other 2/3 may get bleeding and therefore loss in vision, or worse still, the scarring can lift the retina off the back of the eye, causing a detachment, and then they need major surgery to repair that.
It could cause loss of vision and
causing loss of vision. And the thing is, with sickle cell, unfortunately, the retina is very brittle. So once it's detached and you actually need to do surgery, there's a high failure rate. So it's incumbent on us as eye doctors that we monitor the patients much more closely and identify these complications sooner so we can intervene sooner so they never get to the point where they develop detachment.
Okay. Thank you so much for that. So Dr. Zainel, back to you. So when you typically see the parents, when they come with their children affected with sickle cell, are there any guidelines you give them towards the prevention of or reducing the manifesting of sickle cell anemia? So ways that could curtail the symptoms, you know, are there guidelines you give the parents in helping to alleviate the say occurrence of pain crisis and all that?
Yes. Yeah, I think that is very important question, and all the parents should know how to handle their children with sickle cell disease. So, first of all, we need to understand what are the common manifestation of the sickle cell disease. The most important thing is pain, and they can also get infection and anemia. So why they get pain, why they get infection, and why they get anemia? So basically, when sickles and in sickle cell disease, you know, the red blood cells, when they get stressed because of less oxygen or the body has less water, they get abnormal shape, and it can cause the reduced blood supply to the different parts of the body. That is why children with sickle cell disease get severe pain. So we need to avoid this stressing scenario because of the dehydration, because of the less oxygen. So basically, always so how we can reduce the sickle cell children dehydration is, you know, we need to avoid dehydration. So they should drink a lot of water. When they go to school, parents need to make sure that they have enough water to drink. So that is one of the things parents should make sure that they drink a lot of water. The other thing is the infection. So they are prone to get a lot of infection because of the sickle cell disease and sickling of this red blood cells. The function of the spleen is one of the organ in the abdomen, which is very important to prevent infection. So the function of spleen is affected in sickle cell disease. So one of the things parents should do is preventive antibiotic prophylaxis. In children, we do recommend penicillin. Penicillin is an antibiotic prophylaxis every day that will prevent infection.
Okay. Okay.
Another thing is when they get pain, immediately they should seek advice from doctors if it is a severe pain, or parents should keep pain medicine at home. Sickle cell pain can be very severe, so they should proactively start pain medicine, and if not getting better, they should go to the hospital to get pain medicine. And other thing is sickle cell children should have fully immunized, and they should get vaccination on time so that it can prevent infection.
Thank you so much. So what I hear here, the advice is given to parents who have children suffering from this condition. There's the emphasis on keeping them hydrated. And so if they go to school or other places they find themselves, they always have water bottle. And too much of water at times is never too much. You just drink. So we don't want to expose ourselves, especially for sickle cell anemic patients, to a condition that will dehydrate you. So there's the constant water, and then also the need for prophylactic antibiotics. Prophylaxis is just preventive, big word for preventive. There's a need to give them antibiotics, penicillin every day, because they are in a state of autoimmune suppression. And so we don't want to get a case where they have infection. And so there's a need for prophylactic antibiotics. And also pain. Oh, wow, you can never overstate the issue with pain crisis. I hear patients talk about the stabbing sensation. So there's need for parents to always have strong pain medicines, and finally, they always have to be vaccinated, again, because they're in a state of suppressed immunity. So you want to stay ahead. The children, they always have to be constantly vaccinated ahead of their schedule, actually. Oh, well, in line with their schedule, their vaccination schedule. Dr. Mansi, so in talking about the primordial prevention now, I don't know if in the area where you are currently in the UAE, are there initiatives or programs that actually that focus on the prevention of sickle cell anemia, knowing that there's a high prevalence in the, especially in India and the UAE? Are there any programs or initiatives that talk about, okay, how can we prevent this condition to start with?
Yeah, so as I mentioned, sickle cell disease, as actually you mentioned that Nigeria is the sickle cell capital of the world. The second highest number of sickle cell patients are actually in India. But unfortunately, sickle cell disease in India affects the tribal communities. It's like disproportionately it affects the tribal communities. It is sad. And sickle cell disease has been designated as the neglected tribal disease. So NTD, that's like an entity, and I also didn't know. That's probably because the burden is mostly on these tribal population in India who have really no access to health. It impacts the socially, politically, and economically weaker section of the society in India. So more recently, there has been some initiatives in India, especially, which are, kind of looking at what they can do in order to, one, prevent sickle cell disease, and second, how to mitigate the way for these patients who are already affected with sickle cell disease. Having said that, Ministry of Tribal Affairs in Government of India has started the Sickle Cell Disease Support Corner, where they are actually gathering all the information that they have regarding sickle cell disease in these tribal areas. And there was a pilot newborn screen as well that was conducted in the state of Maharashtra and Gujarat. And they found out that the incidence of sickle cell, not only disease, but trait and disease is somewhere between 2 and 40% in the same area. So, there are clusters of patients who are there in the state, but they are, at a specific area. So now they're looking at, implementing newborn screen for this, especially this area where we know the incidence is really, really high. And also there are awareness camps that are going on right now. Awareness not only for the community, but also for the general practitioners, because, as we all know, sickle cell disease is not prevalent everywhere. There are only certain areas. So not everybody is well versed with what needs to be done with patients who have sickle cell disease, who come in with pain crisis. Not everybody knows how bad the pain could be. We have learned this, heard this, done this. When sickle cell patients come initially, when back like probably 15, 20 years ago, I mean, nobody would believe the pain that these patients have was so severe. Now we know what it feels like because, over the years, we've realized that. But early on, it was a nightmare to, have a patient in the emergency with such a kind of pain. And, the residents, the fellows, they were probably unaware of the kind of pain these patients were having. So yeah, these are some of the things that are happening at the ground level, at least in India, and that is the initiative from the government of India. Yeah.
Yeah, while really learning much about sickle cell, my attention was drawn to Nigeria. I heard of this bill passed in 2020, I think, that actually tried to control the, if I should use the word coupling, that's my term, people with traits, so AS, getting married and actually preventing, maybe preventing might be so much of a strict word, but
yeah.
telling that,
not to get married.
Yeah.
Advising them not to get married.
Yeah. In my mind, I'm like, I wish we could live in a world where I feel it's sort of an encroachment to one's maybe rights, but I get it. I'm looking forward to a day where that should not be an issue, because I actually I'm a carrier of the traits, and when I was getting married, luckily for me, my spouse is AA. So that really wasn't a factor. And it's sort of, you're dating in the early time, you're asking the person like, so what's your blood type? It's a little bit of, so I wish, that is something that in near future is something we shouldn't worry about, and such bills will want to, I wouldn't say get rid of them, but there won't be need to address that. We live in a free world where there is a cure, and elimination of this condition. Oh, so
no, but to answer this, it's really soon. I think we're going to head there really soon, is where, when we have we say that when we are pregnant, around 8 or 12 weeks of pregnancy, you can actually test the fetus to know whether they are AA, AS, SS, and at least get that option to the parents. I mean, having we know having a sickle cell anemia patient could be not even like, it's more than, what should I say, like a disease in the family. It's more like having mental, burden kind of thing. I mean, it's your child, you want the best for your child. But again, having that say that, okay, you are going to have a sickle cell disease child, having that say, do you want it, or it's okay to abort it? I mean, that can be devastating, but we are moving there, and people are going to have that choice.
Yes. Like I said, you can't overstate the effects, the toll it has on the quality of life for those affected. So, it's just so much. Advice, let me remind our viewers, please feel free to ask questions. There are so many questions here, and we probably might overrun a little bit, but let's try and keep it moving. So Dr. Farhad, the next question I'm going to ask, and this has to do with the retinopathy. So I remember when talking about diabetic, we talked about, okay, it was floaters with you, not but being an expert in the retinal medicine, I know when looking back, say for instance, in patients with diabetes, you can somehow advise them on control of their diabetes so it doesn't affect their eyes, try to monitor the sugars and all that stuff, controlling the HbA1c and all that. Is that the case for sickle cell? Can you actually advise your patients, people with sickle cell, give them any advice to reduce the incidence of sickle cell retinopathy? Is that possible? Or is just something that's inevitable?
I think that's a really good question. I think, first of all, I think it's important to put things in perspective. Okay. So it all depends on the type of sickle cell that you have. So if you're HBSS, the incidence of proliferative retinopathy, not sickle cell retinopathy, but proliferative, where you have abnormal blood vessels that potentially can threaten vision. That's about 1 in 100 eyes. And in HBSC, which is a kind of milder form of sickle cell, but possibly because it's milder, it means that you're getting more chronic ischemic retinopathy, or more lack of blood flow. There, the incidence is about 4 times, so it's about 2 in 100 eyes. So it's not every patient, not every sickle cell patient will be afflicted, but it's why me and many of my eye colleagues in the UK just screened every Afro-Caribbean patient with sickle cell anemia, and we had agreements with the local department because we were very keen to identify. But unlike diabetes, where if you've had diabetes for longer, if your sugar control is poorer, I don't think the same can be said for sickle cell. I think potentially or theoretically, if you're on things like hydroxyurea, some of these newer treatments, I can never pronounce them, I think it's crolonizumab or something, potentially, or patients who have frequent blood transfusions, maybe they're getting fewer chances of, less progression in their sickle cell retinopathy, but I don't think you can definitely be confident or prove that is the case. There was an interesting study that looked at some of the risk factors, and I think the only risk factor that they found that was strongly correlated with proliferative retinopathy was a history of smoking. So that is something that I do tell my patients with sickle cell to abandon the risk of smoking in order to potentially reduce the incidence of proliferative sickle cell retinopathy.
Okay. So that's one take home, cut down on smoking. If possible, we always advise go cold turkey if possible on smoking, Okay. Yes, just like Dr. Mansi was saying, through the years, there's been so much of if I should use the word innovations in the treatment of sickle cell. Now we're talking about gene therapy, which wasn't the case before. But Dr. Abedin, I just want to ask you now, just to summarize, currently, what are the modalities of treatment for sickle cell? Now, this could be worldwide. What are the various therapies we have for the treatment, management and treatment of sickle cell? Like you're muted though. You're muted.
Okay, sorry about that. So I think we can divide first. I think we already talked about how we can prevent pain crisis and infection. The other thing is, in spite of all these things, still they can have pain crisis, they can have infection. So the management is the specific to sickle cell disease, and if any complication happen. So specific to sickle cell disease mainly is hydroxyurea. Hydroxyurea has been in the field for maybe three decades, and it was originally invented as an anti-cancer medicine. However, it has a role in managing sickle cell disease. What it does is it makes some of the hemoglobin increased. That will reduce the chance of sickling, and that will reduce the pain crisis and other complication of sickle cell disease. And usually we can, and it has been approved for use in children for many years now. And so if any frequent pain crisis, we should start hydroxyurea, which will reduce the pain crisis as well as the need of blood transfusion. Recently, there are few medication come up. So that is recently introduced, like glutamine. It's also called Endarin, which is been again approved by FDA. And there are other medication which is also approved by FDA, that is called voxelotor. So these are the new medicine come up in children. Apart from this specific medical management, only the curative treatment for sickle cell disease is bone marrow transplantation. And bone marrow transplantation for sickle cell has been for many, many years. And there are research publication already in the PubMed. If one of the things in bone marrow transplantation is we need to have a matched donor. If there is a matched donor, it's called matched sibling transplant. The result is almost more than 90% cure rate. However, one of the challenge in bone marrow transplantation in sickle cell disease, especially in Asian and African community, is to get a matched donor is very, very difficult. So over the years, transplant physicians have learned that we can use stem cell either from father or mother. It's called haploidentical transplant. And there are publications even published in PubMed that even haploidentical transplant in sickle cell disease cure rate is significantly high. So if we can do the bone marrow transplantation, especially in, I think there are studies that, sickle cell disease in Nigeria is very severe. And even in spite of hydroxyurea and other management, their long-term outcome is not very good. So in this situation, bone marrow transplantation with a 90% result is a very good hope. So I think the other thing we are talking about is gene therapy. I'm not sure how practical it is available, although there are a lot of studies happening all over the world regarding gene therapy in sickle cell disease. I think these are the main treatment available at the moment.
Thank you. So what I hear, you have treatments aimed to prevent the short-term complications and probably long-term, like the use of hydroxyurea to manage pain crisis, to reduce the incidences of pain crisis or sickling of the red cells. But also you have the ones aimed to cure, like the bone marrow transplantation. And of late, there's the gene therapy, and there's well, maybe we'll see how successful that is. It's still on innovation, right? Okay. Now I have questions here for Dr. Mansi from the audience, I think. There is a number of discussions about the advantage of stem cell transplant. Okay, I don't know if there's a follow-up question. It says, however, the sickle cell patient's health is to see. Okay, let me address that first. So let's address that first. What would you say about the advantage of the stem cell transplant, Dr. Mansi? You're muted.
Sorry. So yeah, like Dr. Abedin said, right now, today we're talking about the cure for sickle cell disease, and the only cure is bone marrow transplant. We have to recognize that, yes, we have made a lot of advances in medicine in the past few decades for specifically for sickle cell disease, in terms of the new medicines that are coming up, in terms of how we are doing the transplants. But till now, today, the only cure for sickle cell disease is a bone marrow transplant. The past few years, if you are talking about sickle cell disease in, like, say, sub-Saharan Africa or in Asia, majority of the patients are not diagnosed timely, and they usually succumb to their disease very early on. We talk about high-income countries like US and UK. When we have a patient who has sickle cell disease, yes, they are managing to grow up, they go into adulthood, but still the lifespan for these patients and the quality of life is very much affected. The lifespan is still 20 to 30 years below the normal expected lifespan for a normal patient, for a normal, individual. So to talk about what are the advantages of bone marrow transfer in a patient of sickle cell disease is one, that is the curative treatment for the patients who have a donor. And like Dr. Abedin said, unfortunately, there will be only 20 to 25% of the patients who will have a full match donor in the family. The rest of the 70 to 75% of the patients will not have a full match donor. And over the years, we have seen that if you have a full match donor in the family, the overall outcome for such patients is more than 90%. That means if we have 100 patients who have sickle cell disease, for whom we are doing bone marrow transplant and we have match siblings available for them, then 90 of them will be cured of the disease and will live a normal, healthy life. Having said that, there will still be 5 to 10% of the patients who will either not make it, who either will not have a successful transplant, where it is called a rejection, where they will be back to how they were before the transplant, or they will have a long-term side effect like chronic GVHD and things like that. So having said that, we have to explain to the parents that these are the possibilities even when we have a full match donor available. Sometimes the family just wants a cure. They have suffered enough. The quality of life has been so bad over the years. They are in and out of the hospital every month, staying in the hospital for 5 days on oxygen, on antibiotics. They don't want to live like that. And they are, they explore the option of even doing a half match transplant. We know that half match transplants are kind of high-end transplants. We are not there yet with a 90% overall success rate for half match transplant, but we are close to 70 to 80%. And what happens to the 20 to 30% of the patients is again the same thing. Either they don't make it because they succumb to one of the complications of transplant, or they have a long-term side effect, or they have a rejection from the transplant itself. So the advantage of doing a bone marrow transplant is that you are cured of the disease. That is the main advantage that we're looking at. Your quality of life is much improved, provided, and we know this, provided that they don't have the long-term complications from bone marrow transplant. And in majority of the patients who undergo a full match donor transplant, they usually live a normal, healthy life.
What about the side effects in terms of, because obviously they're going to be on long-term systemic immunosuppression, and then there's a risk of graft versus host disease. So presumably, you've got a threshold for the kind of patients where the risks the benefits far outweigh the risk.
Yeah. And so that is the reason why, we always tell the sooner you do the transplant, the better. That's the first thing that we talk about. Why? Because these patients receive blood transfusion every now and then for the hemoglobin to be low, whether they have the pain crisis or they have the acute chest syndrome. So what happens is, over the years, if they are getting repeated blood transfusions, they get a lot of antibodies formed in their body from the blood transfusion itself. So they are at a very high risk of having these complications from transplant. So that's the first point. The sooner the transplant is done, the better. The younger the patient, the better. Second, like we said, if you have a full match donor and the child is less than 16 years of age, and this has been done in 1,000 transplants, this was recently published. They looked at 1,000 transplants for sickle cell disease only, and only who underwent match sibling donor transplant. The outcome without GVHD was 90%. That is what we are talking about. And the third thing is, still I'm not saying we are there yet, but, we are still using bone marrow as the stem cell source. That causes less of a GVHD when you perform a transplant versus when you take stem cells from the peripheral blood itself. So from the vein versus the bone marrow. So right now we are still in pediatric patients. We are using bone marrow as the source because it causes less graft versus host disease. So those are some of the things that definitely have to be kept in mind when we are talking about transplants for these young kids.
So in summary, really, the advantage, like you said, it's the cure, really. The transplant is the cure. But then talking about a match for that bone marrow transplant might be, that's something to consider. So the availability becomes something to talk about. And even when this match is, or you're able to find a match, then there's the age criteria. And also, if I was hearing you right, the immune status, does that also determine ability to be to undertake transplantation?
So sickle cell patients' immunity is totally normal. There is no problem with the immunity, but we do give them medicines so that they don't get this complication called graft versus host disease. And it usually we give them for about 9 months to a year. And it's actually very well tolerated. We monitor levels and things like that. It's very well tolerated. We don't see increased infections, which we were seeing earlier, probably a decade or two ago. Now things have really, streamlined, and we're not seeing a lot of infections in these patients with this kind of immune suppression that we are doing, and it lasts for a year. In kidney transplants, though, this immunosuppression actually lasts for your life. But in bone marrow transplant, it's only for a year.
Oh, okay. The immune suppression is shorter for bone marrow than in kidney. Okay, I didn't know that. Okay. Let's see. This is your questions. The question here, I'm not sure if this is a question or an opinion. However, the sickle cell patient's health is to see increase, but some challenges are seen through certain patients. I meant sickle cell patients receiving, no, I'm not too sure this is, if this, sorry, I'm talking out loud here. I'm just reading some comments and trying to get some questions here from our audience. Okay, but while I try to sort that out, let's default back to you, Dr. Quayle. So how often do you see patients with sickle cell retinopathy? Just give us a sense of how prevalent this complication is. So in your clinic days, say a week.
Yeah, so certainly in the UK, I would see them every week. So say I have my clinic of 15 patients, at least 1 or 2 sickle cell patients. And like I said, because we had an agreement with a local hematologist, the government wasn't going to screen them. Opticians in the high street wouldn't be comfortable screening them. So it had to fall on the shoulders of retina specialists. And at the end of the day, as doctors, when we realize, particularly when there's avoidable harm, we just have to accept the responsibility and see them. And I would see them anywhere between 3 monthly to 1 year intervals, depending on their disease. So if they were non-proliferative, I'd see them once a year. But if there were changes, and particularly if I was concerned, I would monitor them much more closely. As I said to you, the figures I had before, not every patient will develop retinopathy, every HBSS, every HBSC, but it's still anything between 1 to 2%, which is quite high, if you ask me. So I think, there, and we've got to realize by the time that as those, so that's, one. So with HBSC, for example, it's 200 eyes per year. But as those sickle cell patients become older, the prevalence increases. And so, over my 13-year career as a consultant back in the UK, you're finding that in the beginning, you weren't seeing very much pathology, but, I was really glad that I was screening them. But by the end of my time in the UK, the proportion or the prevalence of proliferative disease was kind of 50% within that group of patients that I was monitoring. But fortunately, in a third, I didn't have to do anything. But then the other 2/3, we would give panretinal laser photocoagulation. So that is a laser treatment to the areas of retinal neovascularization. But also we do something called a fluorescein angiogram, which would allow us to identify exactly which parts of the retina were deprived of oxygen. And we'd also target laser to those areas in the hope that we're slowing down the progression of that proliferative disease and preventing vision impairment. There has been a new development in the use of anti-VEGF agents. So these are injections blocking growth factor within the eye, We've been using them for the last decade in age-related macular degeneration and for the treatment of diabetic macular edema and retinal vein occlusion. So these are the kind of bread and butter retinal diseases that we see as retinal doctors. But we're now, or I've started using them in the odd patient who presents, say, with vitreous hemorrhage to hasten the clearance of the blood from the eye, so to rapidly improve that patient's vision and to enable me to have a view to then start applying retinal laser to really cure the problem, burn out the changes, and prevent relapse of the bleeding and vision impairment. So our ability to manage and treat these eyes has become slicker. We're definitely emphasizing more on medical management, be it with laser, be it with anti-VEGF therapy. And what we're wanting to do is to avoid the progression and neglect of these eyes, so that what we want to avoid is that proliferative disease, those abnormal new vessels progressing to an extent where the retina is being pulled off from the back of the eye, and then they need a vitrectomy, as in a big surgery to flatten the retina back to reattach the retina. And we want to avoid that because in sickle cell, unfortunately, the retina is brittle, and so the surgery has a high failure rate. So anything we can do by screening them regularly and intervening early medically is giving us has meant that we're getting better outcomes, and very few patients are getting to the point that they need surgery. Sailing in my hands.
Okay, so yeah, and this is I know you did mention the manifestations in sickle cell. SC is different from SS, but I think the scope of this discussion mainly is on the SS, so the sickle cell anemia, you know. So we really are running out of time, and there are loads of questions, but if we can just mention a little bit on one aspect, and that is I've read a little bit about the gene therapy. It really hasn't been talked about. I know there's something about the CRISPR. Is it something that is it something that's an innovation that's at work? Is it a modality of treatment you apply? I mean, can you tell us about the advances with the gene therapy, Dr. Abidin? Is it something that's common, or there's still more research in it? Is it widely applicable in terms of using in the management for sickle cell?
So gene therapy is question to me, yeah?
Yes, sir.
Yeah, gene therapy is, I think it is under investigation. So it is a kind of a transplant, I would say. So what they are saying, you know, the diseased stem cell, the stem cell means the mother of all the blood cells. So they take the stem cell from the sickle cell patient, and outside the body, they will edit the gene, the abnormal gene of the stem cell, which used to produce abnormal red blood cell, so that this stem cell, if we give back to the patient, they will make normal red blood cell. That is all about gene therapy. Basically, the gene of sickle cell disease, gene mutation, which is causing the sickle cell disease, will be edited outside the body and give this corrected stem cell back to patient. So it is not as easy as we explain. So basically, of course, there are advantages compared to bone marrow transplantation, because bone marrow transplantation, taking the normal cell from another person, so that can cause GVHD, that can cause graft failure. However, this is the original stem cell is from the patient itself. So that may not cause GVHD. However, we need to give chemotherapy to the patient before we infuse this stem cell. That can cause complication. moreover, the expense, it can be very expensive. So there are a lot of information we need to know about this therapy before we actually put this into practice.
Okay. So there's still much more, I guess, research and to be done with the gene therapy. Somehow, I'm hoping this promising. You know, I've seen some trial cases, and it feels to be promising, and I hope it's something that will be widely applicable and affordable too. You know, the one thing that impresses me with so much of innovations, you know, being researches in the sickle cell, the main thing is affordability in places where it is highly prevalent. You know, we can get all the gene therapies in the world, but if it's not going to address the people that mainly are affected by sickle cell, i.e. sub-Saharan Africa, it's not, if it's not, and India, you know, if it's not made available to the people really affected, then, you know, so much will be defeated. So I'm hoping one day we'll get to that point where, yeah, so much of innovation, the cure and all, but it's really those that it's going to really meet, is going to address to the needs of those highly affected, where the we have cases of high prevalence. It is past our hour, and actually I'm hoping we can have a follow-up on this topic, because like I said, it's something that you can never, there's just so much to talk on sickle cell. So I'll just ask you, and the three of you, for any final thoughts before we close on this discussion, because, you know, it is a very huge topic. So Dr. Ibedi, I'll go back to you. Any final thoughts maybe on the management of sickle cell upcoming? Okay, this is going to be something that's upcoming, something we should look forward to. I mean, any final thoughts on sickle cell, Dr. Ibedi? I'll start with you.
Yes, I think, you know, of course, you know, the most important thing is, you know, whatever the, you know, a treatment available, we should try to make it accessible to patient with sickle cell disease. That is the way we can say that we are successful and science is successful. So therefore, it is important. The first step is to make lot of awareness among, you know, African countries where children and other patients with sickle cell disease are suffering. So improve the awareness and understanding about the sickle cell disease. That will improve the outcome. And moreover, you know, we need to do everything possible to, you know, make all these things available and accessible to patients with sickle cell disease.
Thank you so much, Dr. Ibedi. How about you, Dr. Mansi? Any final thoughts on sickle cell?
Yeah, I think a lot has been done and a lot has changed in the past, I think at least a decade. You know, there has been talks about new therapies, medical therapies, plus bone marrow transplant. And with this, the advent of new therapies is welcome. It has been a long time coming. And one reason is that, you know, the sickle cell disease is you know, in theory, it's like a simple single mutation that happens in the body, but the biology of the disease is very complex. And a lot has been done. As I said, a lot of progress has been made in the field. And, you know, and I think we are all very optimistic looking at what lies ahead. Again, gene therapy, I think, is very, very promising, definitely, but still under trial. And once it's available to the masses, like we are all saying, that it should be made affordable, it should be accessible to all the patients who actually are in need, not only in the you know, high income countries, but where actually people need it. That will be fantastic. But what we don't know about gene therapy here is that, you know, what would be the long-term effects? We don't know, you know, we do some manipulation in the gene outside the body and we give the same to the patient back. What happens like 10 years down the line, 20 years down the line, we don't know that. So it's still like it's still in trials, it's still a baby that needs to grow up. But the field of bone marrow transplant definitely has evolved a lot, from matched sibling transplant to haploidentical transplants. They are coming a long way. It's coming in a big way, because there are a lot of manipulations that we can even do to the donor cells that we give to the patient as well, in order to decrease the complication from these kind of transplants. So yes, a very exciting field indeed. Very hopeful.
Yeah, we're all so hopeful. How about you, Dr. Fahad? Any final thoughts?
Yeah, I mean, I think if I haven't made it clear, it's really important, any patient suffering from sickle cell, it's really important to get regular eye screening with their local retina specialist. And then he or she will then dictate how often they need to be seen. What I want to avoid is that kind of severe presentation where a patient goes to the doctor because they've got loss of vision. Then although it's rescuable, you're having to put a lot of effort in terms of injections, laser, to try and roll things back and recover vision. What would have been better had you seen that patient from the beginning, detected those changes that were potentially sight-threatening earlier, and intervene earlier, and keep the patient from harm's way and keep them oblivious. So they're never aware that their vision's it's being threatened, because you're ahead of the curve and ahead of the natural history. But it can only be done if patients make sure that, in addition to all the other doctors that they're seeing for this condition, that they don't forget the eye specialist, because it will affect the retina, and early treatment leads to better outcomes, whatever disease you're dealing with. And it's no different to the eye, but especially for retinopathy, early treatment lead to better outcomes.
You know, it's good to know, because the last webinar we had was on glaucoma. And I remember our doctor did tell that once there's a case of blindness, it's irreversible. But what I'm hearing you say, yes, this could lead to vision loss, but with laser treatment and all, it can be reversible.
And anti-VEGF treatment. So, you know, I had here in Dubai, sometimes you do see the severer presentation. So because we have, I've had a couple of patients fly in from Africa because they've had sudden vision loss, and unbeknownst to them, they're unable, they have no idea why that would be the case. And then we've detected that they have sickle cell disease, but we've been able to rescue them successfully with anti-VEGF injections, with laser treatment. But yeah, it would, you know, it's obviously makes more sense if you have this diagnosis, be ahead of the curve, get those regular eye checks, eye screenings with an eye doctor, and get the treatment earlier rather than later.
Thank you so much. You know, this, I'm going to be a little bit partial here, because this forum caters primarily to our viewers, the people in the non-medical field. I'm going to ask Dr. Mansa this question quick, because she talked about bone marrow transplants. The question here is it true that bone marrow transplant for female patients can cause infertility? Is that just a quick yes or no? And, you know, can it cause infertility in females?
Yes.
Oh, okay.
And it can cause infertility in males as well, not only females, but males as well. So it all depends what stage of puberty you're going through. Because of the medicines that are used in bone marrow transplant, there is a chance that you can become infertile. But again, depends on where in puberty you are. If you are pre-pubertal, that chance is probably 40 to 50%. But if you are post-pubertal, that chance, if we are not doing, you know, we can do a oocyte preservation, or we can do a sperm preservation. If you can do that, we give that option to the parents. If they are pubertal, if we can do that, let's do that, because later on we can use this option to make their own babies. But once they are pubertal and we have not done this, then there is certainly a high chance that they will not be able to have children of their own.
Okay, so the older they get, the more the chances of
being infertile. Yeah,
that answers the question. Okay, I'm sorry, so sorry. That is all we're gonna take for now, because we have well exceeded our time. For our viewers, just to inform you, there is going to be a live events. Unfortunately, this is going to be restricted to our viewers in London because it is it is a Valentine's special, and it's going to be on our website really to inform you more about this. It's body aesthetic events, and we're going to, if you remember Dr. Tilo, a plastic surgeon, he featured in one of our very first webinars. So we're going to have the time to see him and answer questions, ask questions and all. So do not miss it. We're going to post the link on, I think it's actually going to be on the chat there. So you can register to participate. And who knows, one day we'll all be able to meet in our various communities to have live events. But yes, this is only going to be restricted to those in London for now. And if you can afford to participate, you can, fly over, depending on what part of the world you are. Okay, so thank you so much. Appreciation to the Moorfields Eye Hospital and Virgil Medical City for very distinguished guest speakers, Dr. Zainal Abidin, Dr. Mansi Sachdef, and Dr. Farhad Cahill. Thank you so much for honoring this invite. Thank you so much for informing us, giving us more insight to this condition. And I hope you can join us some other time, because we really were not able to exhaust. I have a pile of questions here. I actually barely went through half of them. So it just shows that, this topic is really, you can never exhaust on the questions regarding sickle cell. Thank you so much, my viewers, my guests. As always, shout out to everyone. And to the Animal Health team, thank you so much. So until our next webinar, I hope you all have a wonderful evening, afternoon. So right now in UAE and Dubai, it is 11, I'm thinking, right? Sometime past 11. Okay, so good night. Have a
good night. And thank you ever so much for the kind invitation.
Thank you very much.
Thank you. Bye-bye.
Thank you. Bye-bye.
My other speakers, my other guests, other parts of the world, Nigeria, London, in the USA, it's still afternoon over here, and other parts, Canada, Australia. Thank you so much. Hope you have a wonderful day, evening, and have a wonderful night. So take care and good night. Bye-bye.
Bye-bye.